Thank you so much for joining us today, and we're just so excited to have you. I'm Kim Mayo. I'm a program specialist with the DRCHSD program, which is providing this webinar today. The DRCHSD program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. This is the sixth webinar and the final webinar in our telehealth series. The webinar today is being recorded and will be posted to our website. Kayla Blazinski will be sending out the recording and the slides to all the participants for all the sessions at the conclusion of today's webinar. He'll be sending that out shortly. After today's webinar, an evaluation of the series will also be sent out. So I just want you guys to be aware of that. This information just helps us to improve and tailor our content. So your feedback is very important to us. And towards the end of the presentation, we'll also include a link in the chat box so that you can have an opportunity to go ahead and fill that out. Before we get started, just want to put a shameless plug in for some other upcoming Delta webinar series. So starting in April, we'll have a 3-part webinar series devoted to providing an excellent patient experience, which begins April 8th and it runs through April 22nd. And this again will be held on Thursdays from noon to 1 the Central Time. So can't wait for that. I know that'll be a great opportunity as well. And again, we just welcome you all to today's telehealth webinar on telehealth analytics. And many of you are already doing it, but if you'll take a moment and find that chat box, type in your name, your title, and your organization, this really helps us to give us a feel of who's on with us today. And with that chat box, we encourage questions and discussions. So you can either put them there or you can unmute and just talk away. We'll be happy to engage in conversation any way we can get you. We do ask if you are not speaking, if you'll go ahead and put yourself on mute. That really helps to cut down on feedback. Now I'd like to introduce today's presenters. We have Donna McHale. Donna has over 30 years of healthcare industry experience and is a leader in Huron's healthcare technology services. And we have Jessica Duke, and Jessica has over 16 years of experience in the healthcare industry and is a registered nurse with experience in patient care management, process improvement, and telehealth. We also have Carrie Gailey with us today, and she'll be joining us a little later, so we'll introduce her then. So for now, I think we'll start things off and turn things over to Donna.
Thanks, Kim. So this is exciting. We're going to talk about analytics. This is one of our favorite topics to talk about, and it's a nice way to pull the whole series together around making sure that you have the tools that you need to be able to have a high-functioning telehealth program. So today we'll talk about analytics and how to use it, and then walk you through a maturity curve in the journey of analytics. We like to talk about this as we're discussing analytics. And then talk a little bit, Jess is going to come in and talk a little bit about why analytics is important. And then give you some key performance indicators around telehealth that you may start tracking if you're not. And then Carrie's going to come in and talk to us about how she measured her telehealth program success while she was at Cleveland Clinic. And then hopefully we're going to have a really vibrant panel discussion with all of you on our last session. And then I'll give you a couple of takeaways. So next, Kim. So during today's session, we hope that you learn about analytics and how you can use analytics in your telehealth program. And then to understand the maturity curve for analytics and how you can move from descriptive to predictive. It's an interesting journey. And then why it's important to measure telehealth and how you can do that with some of the KPIs. And then you'll hear Carrie's success, and then of course to network, because you've got a lot of great folks here. So some from 17, 18, 19, now the 20 cohort. So this is pretty exciting. Next, please. And then as Kim has said, there's a lot of ways that you can chat. You can raise your hand. You can raise your hand in the Zoom meeting, or you can just send a chat box, because you can see we're all already in there. So feel free to jump in. So next, please. Okay, I love this slide because this is one of my favorite depictions of data. And if you think about data like it's your dashboard or your windshield, I mean, with dirt on it, you know, you can see through it for a little while, but then as the dirt keeps piling up and you go longer term and you don't do anything about it, it's hard to see through it. And I like that as an assimilation around the data, because you can have all this data, and if you don't do anything with it or you don't care for it, then you can't make it actionable. And so one of the things that we like to talk about is, as you're looking at data governance and the management of your data, it's really important to make sure that your data is discoverable, that you know where it is and how to get to it, that it's accessible, again, that you can get to it, and actionable. You know, we have a lot of data, but we're not, you know, everybody's not using it for as actionable information. And to make sure that it's understandable, because there's a lot of data that we have. And even if we put it out into a report or dashboard, it doesn't mean that people understand the information that we're providing to them. So next, please, Caleb. Who's running, Caleb or Kim this time? Caleb, yeah, okay. Okay, Caleb's back, everyone. He just had a baby boy, so we're so happy to have him back and congratulate him for being a new father. So this was an interesting survey that HIMSS did with some senior healthcare leaders around data. For standardization, it was interesting to see that the average number of different analytical tools that the health systems are using is 4. Think about that. Within each health system, they have 4 or more analytical systems that they're using. And even though about 93% of the health systems had an analytical strategy, only about a third of them had implemented it. And then lack of consistency. This is another one that many people struggle with, is that about 25% of the healthcare organizations can use their analytics throughout their entire system. That's really a low number. But the one that really surprised me and bothered me the most was this: that clinicians are the least likely stakeholders within a healthcare organization to use analytics for decision making. Go to the next slide, please, Caleb. Because it was so bothersome to us, we like to talk about it a little bit. So how can you engage those clinicians? Because when you look at your workforce, you know, clinicians make up the majority of your workforce at your organizations. So if you're giving them data that they're not using, there's a problem. So how can you help them? So what you need to do is make sure you get the right amount of data at the right time in the right way. So it has to be real-time data for them, and give them a picture of the entire view of something, whatever it is you're showing them. So that's very important to the clinicians. This one, this should be like bolded red and flaming. Make sure that the data that you provide them is accurate and that they can trust it. When we talk to organizations about their data, this comes up as the #1 thing as an issue, that they just don't trust the data. And they don't trust it because there's no source of truth. And I'll talk to you about that in a minute. Avoid alert fatigue. You know, the great thing with our EHRs is that they have all these alerts, but the bad thing is they have all these alerts. And so sometimes you're over alerting. So I think a lot of us have already taken precautions to make sure that we're not over alerting. But this is another area of why clinicians are not using the data. It's because there's just so much coming in that they're like, I don't know what I need to do and what is important and what's not. And so also look at your EHRs to make sure you're optimizing the decision support functionality. A lot of organizations are not doing that. And then this is another key component. Make sure that the way you present the data, and we call that visualization, so the way the data is visualized for the clinicians, it's easy for them to read, understand, and use. So when they get something, they know, oh, okay, I can understand this and I know what to do with it. So next, please, Caleb. So what is this data integrity that I just talked to you about, and how come clinicians and providers don't really trust it? Well, if we look at what does wrong look like, there's no source of truth. There's a lot of different systems out there and they all contain the same information. So what is that source of truth when you look to one data element in it? For example, admitting physician, this is one of my favorites. What system generates the source of truth for that key piece of data? Inaccurate reports are there for wrong. It's hard to visualize the data. The quality's poor. It's not sourced, so you don't know where it's coming from, and it's not used. So then on the opposite, you can see what right looks like, is that you have the one source of truth. Your reports are accurate. You can easily visualize them. You have solid quality with what's going on. It's well sourced, so you know where it's coming from because you have your source of truth, and it's used by all. Next, please. I love this sign. This is something that a colleague of ours pulled over along the expressway to take a picture of. It was a hospital that was promoting their quality scores. Now, if you look at it, and it's really nice, and it's paid for by a nice group, I'm not sure that you really understand what they're trying to say here. So this is great that you've got quality scores of 12.5 and outcomes and so on. But for us, we might understand that, but would your consumer understand that? There's nothing that ties to anything here. So this is just another example of making sure that when you're putting the data out there, that people understand what they're seeing. Next. There's a lot of different places you can use analytics. We've identified a couple of them, as you can see. Population health, you can use it to do some of the risk scoring for chronic diseases. And this is an area that, as we're talking to you about telehealth, we're identifying that this is a great segue to enhance your program and move it into chronic care management and population health. Compliance, I think a lot of you are already doing that. But then around patient safety, this is another area that you're probably using it to prevent and identify the adverse effects. So there's just a lot of different places to use analytics. It's very strong, it's very powerful, and we're going to help you kind of get it organized so that you can use it well. Next, please. So a lot of organizations have data, but they're not using it where we would like them to be using it as a strategic asset. And why not? Because they don't have it organized in a way as we've been describing so far. So when you look at the maturity curve of where organizations are, if you look at foundational, it's recognizing that the information does have some value. And then you want to move to the next level, which is leading, so that you're starting to get a governance group, or at least a group around data governance and data management, so that you're identifying that source of truth and how you're going to use the data. And then moving to become that transformational organization, so that your information is definitely utilized as an enterprise asset for your strategic planning. You can see that as you move along the maturity curve from left to right, you go from things like multiple data sources to one source of truth. You don't know what the data quality is to information's trusted and proven, and that the technology cost is efficient to manage, to, the costs are optimized and reusable. If you have multiple sources of data from multiple EHRs or different systems, it costs you a lot to manage all that data, so that as you move to having that one source of truth in one area for that data, that it becomes an optimized cost, as well as a great place to have reusable data. So next, please. And as you move along your maturity curve, with your maturity journey with the analytics, there's different phases of getting into the analytics. So the first is an area that we've been in quite a while. It's descriptive. It's the oversight of kind of what happened, doing that retrospective review of what happened. Then you move into diagnostics. So it's hindsight, and you're looking at Why did that happen? Then you're going into predictive, which has been a hot term, buzz term for the last couple of years, predictive analytics. And this is where you're trying to look into the future and say, what will happen? And the latest thing is moving into prescriptive, which is the insight, so that you're using the data to tell you what should be done. Let me walk you quickly through a population health example. So when you look at a diabetic population within your population health, in the descriptive world, you look at what was the rate of diabetic occurrences in the rural populations. And then you move into what were the factors that contributed to that patient having diabetes, the weight, the family history, so on. And then how can I look at that to determine which mix of my patients are at risk for having diabetes? And this is where the machine learning starts coming into place and using different models to predict that 3-year risk of patients becoming diabetic, so that then you can move into what are the things I need to put in place as we're building this population health program around diabetic patients, those who are at risk, to say, here are the patients who are at risk, and what do I need to do to put in place to help prevent them from becoming a diabetic? So just kind of an example of how we've moved along the journey into the different types of analytics. Now, next, please, I'm going to turn it over to Jess.
Awesome. Thanks, Donna. So thinking more about driving the organizational decisions, thinking about the descriptive versus the prescriptive, as Donna discussed, we know that this is going to drive the decisions about efficiently and effectively decisions, right? So the data sources here are your health information exchange, your lab, your imaging, electronic health record, your clinical data, and your claims. That in tune is going to drive your analytics for your operation, your financial, and your clinical decisions. And the whole point of this is your business goals. We want sustainable and scalable goals that are going to filter its way out. The whole point is to have resource allocation, your operations, your workflow processes, and clinical care. And this whole model is still following the suit with having descriptive, diagnostic, predictive, and prescriptive decisions through that analytics. So we can move to next slide. So why is analytics important? It's going to allow us to comply with the organizations that are measuring quality care through telehealth delivery. It's also going to provide that information that's going to help you measure the success of your telehealth program. It's also going to enable you to achieve that quadruple aim objectives that we're all wanting to look towards. So let's dig a little bit deeper in these 3 bullet points that we have here. So Caleb, if we can go next slide. So what organizations are working at measuring the quality of telehealth? Well, certainly we all know about the Joint Commission. And then there's also HHS, the National Quality Strategy. They put out this huge report, I think it was in 2019, looking towards the quality of telehealth and how to start measuring it. And then these other organizations, they are starting to really delve into this. Everybody rushed to put in telehealth with COVID, but now everybody's starting to take a step back and saying, what measures, what ECQMs do we need to start building out to measure telehealth quality of the encounter? There's also URAC. They're providing back accreditation for organizations in the quality of telehealth. So a lot of buzz here right now. We'll go to the next slide, please. So what are the drivers to measure telehealth? Where should you start thinking through as you're diving into analytics and building out your KPIs? Excuse me. The quality of care. The first part that we always talk about is improving the access to care, thinking about reducing those readmissions, the medical compliance of your patients by delivering it. Then there's the consumer experience and access. What's the preference of the consumer, the convenient, the timely and affordable access to the healthcare, the quality of life. And then we always want to take into account the aging population as you're delivering that care. You know, volume and revenue growth is a huge component as a telehealth value. You know, are you able to support the volume growth that you're getting across the enterprise, but also the system leakage? You know, there was a huge discussion during COVID about this, but it's also going to continue post-COVID. And then how are you able to take the changing of regulations and seek out those appropriate reimbursements now? And then we talk about cost containment. You know, how do we reduce costs associated with the underutilization of space, maybe, and resources as a value driver for telehealth? And then even staff efficiencies. You know, is there underutilized staff that we can maybe shift to telehealth modeling? You know, the provider and patient engagement. I think that's a huge component we kind of forget about a little bit with telehealth. But how do we engage more so with our patient with having an intimate telehealth encounter, particularly with behavioral health use case? And then the education component, we're able to deliver a whole nother level of education thanks to telehealth. So those are definitely our value drivers. Caleb, we can go to the next slide. So the quadruple aim, you know, we definitely can achieve this with telehealth, improving population health by preventing and managing those chronic diseases that we've definitely talked about. I know we've talked a lot about it with our 2019 cohort members, and we are planning and gearing up to do it with the 2020s. But there's a lot of prevention that we can do there. There's also the enhancing the patient experience with telehealth. You know, you're motivating, you're engaging the patients, you're playing an active role, you're encouraging them to take ownership of their diseases, improving their outcomes and the safety through telehealth. But you're also reducing the cost of care. You know, your resource utilization and readmissions, you're able to reduce that cost of care. So improving the provider experience is another piece of this quadruple aim. You know, you're accessing the tools, you're able to provide another concept of a tool to the providers. And then the resources by helping with the provider burden and burnout. So that's the more work-life balance that you're able to give back to the providers. So we can go next slide. All right, so this is another component
Jess?
Yeah.
I'm gonna back up a second. Caleb, can you go back to that slide? And Jess, Joshua has a question for us. That we talked about the reimbursement for telehealth. Has there been any concrete outcomes at the federal level regarding using our AR as a payment platform?
All-inclusive rate.
The all-inclusive rate, yeah.
I don't think anything is concrete as of yet, is my understanding.
Right. Yeah. Have you seen anything, Joshua? We haven't seen anything yet. Have you?
I've just heard rumblings, and that's why I was wondering if you'd heard anything more concrete, but that CMS was in fact working with HHS to try and take a new approach to this.
Yeah, and that's exactly what I heard. Yeah, that their House representative, and I can't remember his name, had pushed last week to make it more concrete, but I have not heard that it went through or anything like that.
Okay, yeah, I continue to push.
Yep. And that's what we have to do. Yeah, absolutely.
Thank you.
Yes, sir. All right, so aligning quality of care definitely with analytics. And so Institute of Medicine provides back the performance measurement domains. And I definitely feel like these domains have to align with how we measure telehealth analytics, your effectiveness, you know, and this has to align with the scientific evidence of achieving those outcomes. The efficiency, you know, how is the quality comparable with the healthcare deliverable? And then the equity, we have to have equitable care for all individuals with telehealth. And then it has to be patient-centered. How are we meeting the preferences of the patient? And it has to be safe. We definitely don't want to incur any harm to the patient. And then it has to be timely. It has to be within the minimal time requirements to deliver that care. So if we take these domains and apply it to the analytics, apply it to the KPIs, that will give us the best quality of care to the patients. We'll go next slide, Caleb. So that brings us to the point of the telehealth KPIs, or the key performance indicators. These are our specific business metrics that we're going to use to evaluate our telehealth implementation or the telehealth program. And the purpose of these KPIs is to measure the business goals and how we're meeting the demands of the telehealth program. So we certainly want them to be measurable and realistic performance measures, right? They need to assist us in evaluating the services that we're providing via telehealth, and on a basis of looking at how we can expand the service lines. And if you think about this as if you have a telestroke program and you want to measure like your door to needle time and see how effective you are in meeting the demands of your patients. But then also, if you're wanting to expand that program to say you want to add in neuro, and you can say, here's the success of this program, and we want to expand it to include this additional service line. And that gives you the metrics to look towards that. And then same with the specialty network. So now you're able to go back to maybe your tertiary care setting and say, look, these are the metrics I have to support this expansion of the program. And then, so that's continual with your branding as well. You're able to get back the metrics of the success of your program as either branding or marketing, or however you want to look at that. So that's kind of the concept of the telehealth KPIs. We'll go next slide. So one thing that has been continual with all 6 of our presentations here is telehealth is across the care continuum. So of course we want to measure it across the care continuum. So if we start with ambulatory, thinking through what are the KPIs in the ambulatory telehealth program, you may think towards measuring the number of new and existing patients, or what are the number of telehealth visits that are occurring. What is their request for telehealth visits by the patients, or referrals for telehealth visits? And certainly, what is the patient satisfaction rate for the telehealth experience? If you go towards the acute setting, maybe you're looking towards the chronic illness readmission rates or hospitalizations, and then maybe the number of patients followed by a telehealth visit post-discharge or for their next appointment. In the post-acute care, we're monitoring the KPIs for the number of visits that are not appropriate for telehealth, or maybe it's more towards the IT support for connectivity or device issues, or even monitoring the travel time that you're able, or distance of a patient to provider for the telehealth visit. So now that the patient or the provider is not having to travel, the time saved is what you're going to measure. So that's showing the success of your program because you're able to limit that travel time. So this is kind of measuring across the care continuum, the KPIs correlated throughout your organization. So the next slide. So now that you've thought through the KPIs, how are you going to implement it? How are you going to measure the telehealth analytic program? So obviously you're going to start with assessing and defining what's the environment, the model, the business case for what you want to measure. Then you need to plan and develop. What's the quality improvement, the technology plan, so what technology you're going to utilize, and the improvement strategy. And then you're going to implement and monitor the implementation activities that are going to be part of this whole program, the continuous improvement. And then finally, we have the data reports and the dashboard for your live monitoring. And then we'll go next slide. And I'm going to turn it over to Kim.
Awesome. Thanks, Jess and Donna. Well, we're super excited to have Carrie Gailey back with us today as she shares about some of her experience. So Carrie is a clinician, mother, wife, and patient advocate. She is currently a postdoctoral fellow in leadership at Case Western, a reserve university, where she received her Doctor of Nursing Practice in 2014 and a Master of Science in Nursing in 1997. So after she completed a 2-year National Quality Improvement Program, and then 2015 as a VA Quality Scholar, she participated in multi-site quality improvement program and facilitated the development of a resident quality improvement coaching toolkit. So Carrie, we're so excited to have you with us today and share your knowledge.
Thank you. Next slide, please, Caleb. So I know I talked a little bit before previously about our journey at the Cleveland Clinic in one of our first telehealth programs. And that was more geared towards population health. So I'm going to take that same program, but really focus on what the analytics and the quality and how we use those. And they were integral, and we could never have done this program without both of those aspects. So really what happened in 2016, it was an enterprise initiative, which was all across the state of Ohio, to figure out how we can improve 16,000 lives of patients and touch those for people who had hypertension. So obviously we used analytics to figure out what was our population we were dealing with. We refined it. And then in our specific one for telehealth, we refined it even further. We wanted to look at patients that would be willing to do telehealth and use remote patient monitoring, and that had systolics that we are considered out of control by the national quality metrics that our system we're using and most systems use. And so that helped refine our population even further. We figured we got 10 providers that were willing to jump on board and try this. And so we refined it even better. So we came up with a list of patients that were attributed to those providers, and then sent it back out to them. What they did is we kind of did a high level data pull to get which patients were going to work. And then we had their providers do their magic and say, yeah, I think these patients would probably be willing. And so they kind of prioritized their list until we got to 100 patients that were willing to jump on board and try this remote patient monitoring program. So using analytics from a very sophisticated system to the providers doing that. And really what the goal was to focus on population health and hypertension in specific, to decrease uncontrolled hypertension and to integrate the new technology from telehealth. At least those were our goals. And we looked at how are we going to do this? We got a core group of people together. We really wanted to drive efficiency of the program. We knew this was a learning pilot and an opportunity. And we realized when we asked them, how do you take care of your hypertension patients? Well, it was all over the board. We had a care path. There's national guidelines out there, but there was really no standardized method or communication about it. Everybody learned what they learned at school, and they continue to do it and then maybe some additional reading they had done. So we standardized the process that we were going to have. We shared it back out with them. The providers all bought in. We got a whole clinical team involved and really created some operational definitions. One of the things the organization was doing as a whole was looking at, if you look at hypertension, what's their systolic blood pressure, what were their lab work, what was their diet, what was their exercise, all the other lifestyle measures too. So they have what they call a care gap. And the last time they were in, what their medications were on, all that aligned with these standard processes that we were going to implement. We could pick out from there who was missing little holes in their care gap. And those were the people those were the items we would most likely address. But we were trying, those were all the efficiencies, workflows, and standardized processes that we put in place with the team. And we were also very interested in the patient experience, the family experience, because I ended up coaching all of these patients and collecting data on all of them and sharing it back with both the patient and the family. So for instance, if they had an area where they wanted diet and there was a gap in their care that was identified by the patient and by our system, we focused on that during one of our calls. And obviously, if it was a male patient in their 60s or 70s, they weren't doing the majority of their cooking. So the wife got involved and they participated. So they needed to be happy with the program also, and the care team needed to be happy. And one of the things, as Donna alluded to, is really important to get clinician buy-in, which we invited them every step of the way. But some of the other things that we did is we wanted to give them the information back. And we were using an external vendor. Well, how to do that and how to get the information into their traditional clinical workflow, in what format do they want, what visualizations do you have, were so important. So we decided, there was a system across all 10 different sites and 10 different providers that this is how we would notify them. This was a standardized template. instead of having what they were used to, a list of numbers of blood pressures that the patient had over a period of a week, we put them in a graphic display. If they can look at it, they can see if a line's going up or a line's going down. It's really easy. It's much easier than having to skim. Some of our patients were really excited about the program. They were taking 8 readings a day. So think about 8 times 7. So they'd have to scan 56 readings. A line graph is so much better for them. So the experience of the patient, the providers, and actually I use it as a patient teaching tool to show them, hey, what happened here on this day? And we could debrief about their diet, about things that happened that may have influenced stress, their readings that day. So all these numbers and these data points were integral in how we were efficient in developing our plan, in enhanced experience. And then also what we did is we had key business metrics. We really wanted to figure out, what was the cost of this? How could we implement them? And with the goal of, we were very lofty in our goal, that we were going to be a leader and with no geographic boundaries and be able to provide hypertension care across the United States. But still a goal. But we collected all the data to be able to do this. And our key performance indicators were not only how were our processes working and what workflows needed to be tweaked, could we become more efficient in who did the coaching from the data that we had? How are we most efficient in disseminating the information and communicating it across the care team? And then also, how were the bottom line, how were the clinical outcomes? The thing that was most exciting to all of our team, and we had a very small, very efficient team, was the fact that the inpatient primary care providers also focused on this. They had a 58% improvement. We were significantly above them. So we were like, yes, our program works. So standardization and taking that time to plan and communicate and having definitions and having the data to support it was huge, because they wouldn't have never believed us without the data. And then, other things of what we could do is from that report, we actually ended up working with business intelligence and having a very sophisticated system built in. But I was thinking about how could you, and for different chronic illnesses, how could you do this? Even if you developed a tickler system using a patient list, you could start to think about how could you capture data with your electronic health record. And then what we did is we created a predictive model for patients when they came in with, say you had a patient with 210 over 120, and you had another patient with 210, and we were really monitoring 10,000 patients, which in our lofty goals we could imagine doing. How did we bubble up to the top? Who was most at risk? And so what we did is we created a model based on a variety of different things that seemed to be effective at identifying who was most important to reach out to first. And again, that goes back to the visualizations and dashboards. So Caleb, next slide, please. So here, I wanted to look at what we did. And the nice thing about creating a hypertension pilot is we have had subsequent pilots and now it's expanded. It was really a plug and play template that you could then take hypertension and put CHF in. You could take asthma and COPD and put those in using different devices, obviously, and different workflows, et cetera, but the same basic concepts and principles in line. And then we also did one for diabetes. So data collection, you just have to have the devices and the sensors in there, and what are you going to use? What is the data transmission capacity? Are you using computers, smartphones, tablets? Are there any challenges with those? We use cloud storage for ours, and then it came down into our electronic medical record through MyChart. And then also the other thing is looking at the population and care management. So you're really circling the data so it gets, comes from the patient in real time and transmitted through storage and into the patient and the clinician or clinician team hands to be able to make it actionable, like Donna suggested, is really seamless to be able to do with this process. So next slide, please. And this is what we really, I wanted to show, is that we ended up having great success with the program. We had 62.5% control. I mentioned they had 58% over a year. They took them to get there. We ended up getting it within 8 weeks. We created standardized workflows for our team. They knew what data they needed to collect, and then over time it was automated and just went right into the care gap and was really easy to read some of these visualizations and dashboards. There was a heightened awareness of blood pressures. There was accountability and self-management on the patient side. They were engaged. They really enjoyed. It was kind of a goal for them to be able to see the data and watch it with you and track it over time. And obviously, it was much more timely for medication adjustments to have a program where the clinician had data to be able to act on. And then patients and families and the care team were all satisfied. We did not have one challenge whatsoever that they did not endorse this to their colleagues, and so that it could spread across the enterprise. And then again, as I said, it's really a plug and play framework for all chronic disease management. So next slide. So that is it. So thank you.
Wonderful. Thank you all for such great information. So now it's just an opportunity we'd like to open up for any discussion or any questions that may have been presented that you guys want to talk about. And I do believe on the next slide, there are some potential questions. I'll give you guys a chance to review those, and if anything pops out, feel free to.
Yeah, and while you're going through that, there's a couple of things I'd like to ask. So how many of you have identified your sources of truth? And you can just send us a chat whether you've done that or not. Because I know many of you on the phone have multiple EHRs and multiple systems. So I know that this is an issue. Just curious to see if any of you have started to identify what your source of truth is. Everybody is very quiet again today. And how about in the same vein, have you started to look at your data in a data governance model? Oh boy, Greene County, be careful. They have some tornado in there. So take care, everybody there. So has anybody started to look at the data in a data governance fashion? Joshua or Danny or Lisa?
We've done some analysis, and I think one of the biggest things that you guys had touched on, which is so very true, is having that really core component of truth for your providers for the feedback. And different providers have different beliefs in the data, irregardless of how we're pulling it or where it's coming from. There's a lot of skepticism, and I understand that. History shows that oftentimes our best EMRs are not perfect and not infallible. And I think that providers have a history of getting burned from that, especially when it comes to quality reporting. And ensuring that you can generate buy-in by walking through the reason that you currently trust that data, and whether or not you have actually put some energy behind verifying it. For instance, when we're looking at the time it takes for a full episode of care to occur with telemedicine, we don't just rely solely on the data we're pulling from our EMR, but also from physical logs that occur, and are able to share that with the providers to talk about what seems to be driving the length of these visits. What can we do to improve that? And sometimes there's stuff that you can do to tweak it and make it better. And sometimes there's not. Sometimes it's just a situation where you have individuals on the other end of the line that are hard of hearing, and your nursing staff have to help explain to those elderly individuals what's going on, and really be attentive to the physical cues that they see from these patients, that indicate a lack of understanding, because the last thing we want to do is get done with a visit and have a patient walk away with, the head nodding, going, yeah, we understand, only to find out later that they had no clue what we were talking about.
Yeah.
So our staff have gotten very good at, watching for visual cues and, interjecting, especially with some of our providers who are more prone to try to race ahead just to get to the next visit. And it really establishes a sense of confidence in the data at the end of the day when you're able to provide a full spectrum of analysis and not just use that data to beat them up, but really try to improve care.
Those are, Joshua, you hit on a lot of the questions that we had here and a lot of really valid points. So not only validating what I said about making sure that they can trust the data, but using the data so that it's not punitive. And that's a really big, important thing. It's great to be able to capture all this data, but like Carrie and Jess both said, it has to be actionable, but then actionable in a way that it's educational and that it's not harmful to the providers or the clinicians so that they're afraid of it, so that they'll embrace it a little bit more. So you are actually right on with that, as always.
Thanks, Donna.
And a few of you have said that you're just getting started in this journey. Are you guys using your data? That's one thing that we're always just so interested in, because again, all of these systems that we have in our facilities are gathering data. And it's really the challenge to be able to get to it and then to pull it together so that it's actionable and then show it in such a way that you can use it. So how about some others? Are you using your data for different analytics? I'm sure you're using your data for a lot of different financials, but what else are you using it for? Any clinical decision support or helping you with different strategic initiatives moving forward?
Hi, this is Mary Williams. I use my data for hypertension management, controlling hypertension and looking at patients with above average A1C as well.
Great. So you're aligned with Carrie's program. you and Carrie are aligned. So that's awesome. That's great.
Thank you.
How about others? Well, hopefully as an output of this, you'll be able to have some ideas for how to use your data, because you have so much data and it's so powerful. It's just a matter of how you get to it and pull it together and share it with your providers and clinicians and your executives to really help you along the way. And as you're putting your telehealth programs together, this is going to be an important piece, as Jess said, because you're going to want to know what's working and what's not. These are all kind of new programs to us. And so it's going to be important to start looking at the different metrics that Jess listed out there, and just pick one or two. As Carrie said, they were just looking at, could they decrease hypertension? That was just one goal that they had, and it worked. And so just, start small with that, but it's going to be important as you're going and buying different devices and equipment for telehealth to make sure that you're getting a good return on the financial investment there.
Donna, if I may, I would interject. One of the other things that we have used the data for is to determine the direction that we want to go overall with telehealth from a demand and supply standpoint. So looking particularly at our more conservative access to specialists, how much demand has there been, and is that increasing or decreasing during COVID regarding access to particular specialty services? For instance, we saw a large early swing with need for cardiology, and reacted quickly to that. We also simultaneously saw a big surge early on during COVID in rheumatology.
Yeah.
In particular, because you have very vulnerable populations that did not want to come into a medical facility where they were going to be, potentially exposed. And at the same time, they were those who were most in need of follow-up access to their specialist. So just kind of keeping your finger on the pulse of what does your community want and need, and then how can you best accommodate that while balancing, the cost benefit aspect of that in the background. But it really can be beneficial to guide you in that. And then you had just also had mentioned, looking at choosing the right equipment. And I would highly encourage anybody that's putting together a new equipment package to get a physician champion, or if you're using mid-levels, get a mid-level champion, somebody that's going to come in with your nursing staff and your IT and physically set everything up and then try it and see if they like it. They may or they may not. And there are so many options out there that you're bound to find something that your team really likes, that has ease of use and fits your particular needs. So I would just really encourage hands-on testing with your team before trying to make something go live.
So thank you. Joshua, it's funny because one of the things that Carrie, Jess, and I, and Greg's on the call too, have been helping a lot of our clients with is just what you talked about, that demand modeling. And we almost brought that into this presentation and said, no, we don't want to overwhelm everybody with that. But you're absolutely right, because it's the next place you need to take it, because as we've seen in this last year, we all jumped in March and April to provide something for telehealth. And then May, June, July, things were kind of stabilizing into some sort of a new normal. And so everybody was saying, okay, now what are we going to do? What's our plan? What kind of platforms do we need? What kind of equipment? And then now people are looking at, okay, what are things going to be like post-COVID? So what's the demand going to be? And like you said, Joshua, things were interesting during the first waves of the pandemic, of the people that you needed to focus on and where telehealth was high. And then they're kind of switching around all through the summer and the fall. And so now it's really kind of looking at, where do you need to go with this? Because some organizations have had providers who are not willing to come back to the facility and say, I just want to do things remotely. And others have said, well, I'm trying to figure out what that right balance of in-person versus remote is. And then other organizations are doing, as you talked about too, Joshua, around the specialist. How can we bring more specialists in through the remote care? So again, this is the strength of your data to help you start analyzing what the modeling should be, looking at what your volumes are. What were they March, April, May, in the summer, for each of your quarters last year? And then, how can you use it to predict what it's going to look like for this year, and where should you focus on it with your different specialties? So great points, Joshua. I love having you around because you're so great. It's almost like we planned this with you. You take us right to the questions and topics that we were thinking about. So thanks.
Well, I want to add one last thing, not to dominate the conversation, but
go right ahead.
while real number data analytics are incredibly important and help us prove things out, don't undervalue the feedback from your frontline staff and your nursing staff and those that are face to face with the patients, because some of that uncapturable request can be our biggest guide as far as which direction do we need to turn, and you'll get that feedback quicker from them than you will in trying to wait for a statistically significant amount of data to make a decision. So when you're when you get feedback from your frontline staff that say, hey, we've got a bunch of people asking for, the ability to do telehealth with X, Y, or Z, it's a really good thing to start, listening to that and pay attention to it, and then put some energy behind validating how much of a demand really is there. That early on feedback can be absolutely priceless when you're trying to react quickly.
It's so true. And Carrie talked about the same thing. She got the input back from the patients and their families, which was key, because I think you're right, Joshua. A lot of that you're not capturing anywhere analytically. And so it's really just gathering that data and kind of moving forward. So let's see. Caleb, what did you just put up here?
I just wanted to put the survey link in the chat as we move on towards the end here. As Kim mentioned, if you could just take a few minutes to fill that out, that just really helps us tailor our webinar experiences.
Okay, great. Well, anything else, you guys, before we wrap up a little bit and I give you some important things to take away? Okay, next slide, Caleb, please. So what's going to be important as you look to advance your analytics strategies in your health systems? We talk a lot about thinking, planning, and acting differently. So here are your think, plan, and act differentlys for today. Continue to evaluate whether your health data is being applied to improve clinical outcomes. So we use a lot of data. So are we looking at it to improve clinical outcomes? And then look at all the different unstructured data that you have and how it can be used to come together in advanced data analytics beyond just a single episode of care. So as we've talked about, to look at it across the care continuum and the patient's whole experience. So looking at it that way. And then can you act differently by creating a different set of data assets to foster adoption of data across your enterprise by everyone, by your consumers, your physicians, and staff. You remember last week and the week before, we talked a lot about the consumers and that they want to have data that they can trust. This gets back to that point again, too. So next, please. So what else should you think about? Don't be afraid of data and the analytics around it. Analytics are becoming more and more important as we continue to move into this amazing technology age that continues to grow. And it's important to remember that for it to be successful, it has to be standardized. So make sure that you have that source of truth and that you execute it, you're consistent in its use, and that it's clinically accepted. So we've talked about that a couple of times. And that you really can use it as a strategic asset. You've heard about how Carrie, while she was at the Cleveland Clinic, they used it to develop one of their programs for telehealth with remote patient monitoring. Joshua has given us a couple of examples how he's used data strategically within the organization to determine how they're going to move forward with different programs of telehealth. And then understand that your data, you're constantly moving from that descriptive phase where you're kind of just getting started to predictive, where you're thinking about not only how can I identify the patients who are at risk, but how can I then treat them ahead of time? What can I do to be prescriptive about the patient's health? And then the fact that all of you are working to achieve your Quadruple Aim objectives, and that analytics is your partner in that. Again, that you can measure telehealth across the care continuum. It's not just one place or one part. And that these are all the things that we've pulled from Carrie's great presentation, is that in order for a telehealth program to be successful, begin with the end in mind. Have an idea of what you want to do. So it's kind of like, what should your metric be, or your key performance indicator? For Carrie, in her example, it was to decrease systolic blood pressure. Make sure that you have clinical and IT stakeholders within the group. They're both key. Communicate and collaborate about what that model's going to be. So make sure you get the input from the folks, and then once you get it, communicate it. And then strive to get real-time data, and that the visualization or the way that you show the data or present it is in a way that people can understand. And then capture your lessons learned. You know, this isn't going to be right the first time out, like anything that we do. So make sure that you capture those lessons learned, and then embrace data-driven continuous quality improvement. So Kim, I'm going to turn it back to you.
Awesome. Thanks so much. I really appreciate all the great information that was presented today and all the great discussion. This is our contact information, so feel free to reach out to any of us. We'd love to continue any discussion that we had today. We thank our speakers for just providing such great content today. And we just thank you all for joining us today and watching the webinar and the whole entire series. We do encourage you to check out the other webinars in the series. They have been recorded and will be sent out shortly. And just a great set of tools to just increase your telehealth toolbox practice. So we do encourage you to complete that survey that Caleb posted in the chat. It will also be sent out in an email shortly after. Like I said earlier, your feedback is so important to us. We're so glad that you've joined us today. We wish you all just a great day, the great rest of your day, and that you guys be safe out there. And we'll see you all soon.
Bye, everybody. Have a great day.